Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
Occlusal radiography is a form of intraoral radiography in which the image is projected onto a film packet placed in the occlusal plane of the mouth. It is used to radiographically examine areas of interest in either jaw that are either so large or so located that they cannot be adequately displayed with periapical films. There are two basic types of occlusal projections. In one, the teeth are displayed in cross-section, and in the other, the teeth are shown longitudinally in approximate normal length. The film we prefer for occlusal radiography comes in prepared packets, usually in boxes of 10 packets. The film size is 2 1/4 by 3 inches. It is of the American Standards Association Type 3.4 and USA Standard Speed Group D. It is a high or ultra-speed film. The packets are considered germ-free and, with appropriate care, may be used directly in the mouth. The clear pebble-grained surface facing us is the sensitive side of the packet. This is an excellent example of a maxillary anterior occlusal radiograph. It shows the maxillary incisors in good anatomical relation. The image of the central incisor from its incisal edge to the apex of its root approximates actual measurement. The radiograph includes much of the entire hard palate. The linear midline opacity represents the nasal septum. Now we will demonstrate how to achieve this result. The patient is seated in the chair. The headrest is adjusted so that the medial sagittal plane of the patient's head is vertical. In profile, the patient's head is positioned so that an imaginary line from the ala of the nose to the tragus of the ear is horizontal. The occlusal plane is then horizontal. Using a typodont to demonstrate, note that the film will be inserted with its long axis extending from front to back. It is placed on the occlusal surfaces of the teeth with the sensitive side of the film against the upper teeth and held in place by having the patient bite gently on it. After the exposure has been made, the patient is asked to open and the film is retrieved. To obtain this radiograph, the head of the X-ray machine is set at a vertical angulation of 60 degrees downward. The patient, with her head remaining in the correct position, is asked to open. The film is inserted, as was illustrated on the typodont, and the mouth gently closed. The head of the X-ray machine is now moved into position along the mid-sagittal plane of the patient. The cone is positioned so that the central X-ray beam will pass through the root tips of the central incisors. Note that the patient's lips are closed against the film packet. A convenient method of checking the direction of the central ray is by the use of a taut string, as illustrated here. Viewing from the front, the alignment of the central ray with the mid-sagittal plane of the patient's head may be checked. With all alignments correct and the patient's lips closed, the exposure is made. The film is retrieved and the patient dismissed. This film illustrates a common error called cone cutting. The upper half of the film was not exposed. The central ray was directed at the incisal edge of the central incisors instead of at the root tips. Reconstructing the faulty procedure, note that the patient was properly positioned and the film was properly placed. The X-ray head, although correctly angulated, was not aligned so that the central ray passed through the root tip area of the incisors, but rather through the incisal edge. Another common error is illustrated in this film. Note that the length of the incisor teeth is excessive, and the teeth are elongated. The vertical angulation of the beam was wrong. Usually this occurs because the patient's head position was incorrect. Note in this view that the ala tragus line is not horizontal. So even though the X-ray head is correctly angulated and aligned, the projection is a failure. This is an excellent example of a maxillary posterior occlusal radiograph. Note that the occlusal line of the posterior teeth parallels the bottom edge of the film. The crowns and roots of the upper posterior teeth are clearly visible. The maxillary sinus is well defined and well visualized for viewing foreign objects or retained roots. We're able to see through all the contact areas between the posterior teeth. This is desirable, of course, but may not always be possible. The correct positioning of the patient is again important. The mid-sagittal plane must be vertical. In a profile view, an imaginary line from the ala of the nose to the tragus of the ear must be horizontal. To assist our placement of the film packet, we have marked the embossed dot found near one corner of the film, and also placed a dot in the exact center of the film. Correctly aimed at this center, the X-ray beam will expose all margins and corners of the film. Since the center dot will be hidden when the packet is positioned inside the mouth, we draw in some guidelines that will aid us in the alignment of the central beam. This is being prepared for a right posterior maxillary occlusal radiograph. Note the relationship to the corner dot. Finally, a line is drawn paralleling the border 1/4 inch from the edge. Note that the corner dot is within the border segment. Using a typodont for demonstration, the film is inserted with the sensitive side against the upper teeth. Since this is a right maxillary projection, the 1/4 inch border is positioned just outside the buccal cusp line of the right posterior teeth. The guidelines to the center of the film are visible at the front and side edges. The correct vertical angulation of the X-ray head is 60 degrees downward. The film is now inserted. The sensitive side is placed against the upper teeth, and it is positioned so that the 1/4 inch line is oriented along the buccal cusp line. The center guidelines are clearly visible. The X-ray machine is now moved into position on the right side of the patient. The cone is directed so that the central ray will be aligned with the guideline that is visible on the lateral edge of the film. From the front, the cone must be positioned so that the central beam will pass through the guideline visible on the front edge of the film packet. The film can then be exposed. This film illustrates a common error. Passage of the beam has left much of the film unexposed. This is commonly called cone cutting. It is caused by not correctly using the guidelines to direct the central ray through the center of the film. This is one way cone cutting takes place. Careless positioning of the X-ray head has directed the central ray through the edge of the film instead of the center line. In the third type of maxillary occlusal radiograph, we're viewing the dentition directly along the vertical axis of the teeth. The alignment of all the teeth is clearly exhibited. The entire palate is also shown. The pulp canal of this cuspid is seen as a black dot because the X-ray beam was aligned with the vertical axis of the tooth. The relative position of foreign objects or impacted teeth can be determined with this projection, as well as areas of pathology in the palate or alveolar ridges. Positioning the patient for the cross-section occlusal radiograph is similar to the other maxillary projections. In a frontal view, the mid-sagittal plane of the patient's head must be vertical. In profile, the head must be positioned so that the ala tragus line is horizontal. For this procedure, we must use another method of film packaging to reduce the exposure of the patient. The film has an emulsion on both sides and has been cut from a large-size screen-type film. Films from an occlusal packet are not suitable. The film is placed in an intraoral cassette of lightweight metal. After careful closure, the compression spring on the back is locked in place. Note that there is a letter R on the front surface of the cassette to identify the right side of the exposed film. Since we cannot sterilize this device, it is placed into a small plastic envelope each time it is used. In positioning the film, the long aspect is placed from side to side. The placement is symmetrical bilaterally. The surface of the cassette bearing the letter R is against the upper teeth, and about 1/4 inch of the front edge of the film is anterior to the incisal edge of the teeth. The vertical angulation should be set at 75 degrees and forward toward the seated patient's feet. The film is now inserted into the patient's mouth. The sensitive side is up with the R on the right side. When positioned, the cassette pack will be held against the teeth with the patient's thumbs because even light biting pressure will damage the cassette. For this maxillary cross-section occlusal projection, the X-ray cone is positioned above the head. From the front, the central ray must be aligned with the mid-sagittal plane. From the side, the 75-degree angulation should direct the central ray to the center of the film. The outer corner of the eye is a convenient reference point. The exposure may then be made and the patient dismissed. This radiograph illustrates an error in the maxillary cross-section technique. Note that the roots of the teeth appear distal to the crowns. This is similar to the anterior occlusal view and wrong. This is how the error occurred. Although the central ray passed through the outer corner of the eye, the beam was projected toward the back of the patient rather than forward toward the feet. This is an excellent example of a mandibular anterior occlusal radiograph. The incisors are shown at approximate anatomical size and length. The remaining bone to the lower border of the mandible is well visualized. It is a very useful film for demonstrating impacted teeth or pathologic lesions in the area. For this radiograph, the patient should be positioned with her head tilted far back. The degree of backward tilt will vary from patient to patient, of course. This variance in angulation will be accommodated in the technique, as we shall see. From a frontal view, the mid-sagittal plane of the patient's head must be maintained in a vertical alignment. Using the typodont for demonstration, the film packet will be inserted in the mouth with its long dimension extending from front to back. The sensitive side of the film is placed downward against the lower teeth, and the packet positioned symmetrically in the mouth. It is held in place by the patient with a gentle biting pressure. After exposure, the film is carefully removed. Returning to our patient, again note the distinct backward tilt in which we have positioned her for this examination. The film is inserted as was demonstrated on the typodont. The correct vertical angulation for this particular position of her head is now determined in 2 steps. First, the white line of the X-ray cone is aligned with the lateral edge of the film packet. Then the vertical angle indicated on the scale, in this case 45 degrees downward, is increased through 60 degrees in an upward direction. The final correct vertical angulation for this particular position of her head is 15 degrees upward. Remember that the angulation must be computed in this way each time the technique is used. The X-ray head is now moved to position in front of the patient. The machine is positioned so that the central beam will pass through the root tips of the lower incisors. From the front, the central ray is aligned along the mid-sagittal plane. With all alignments checked, the exposure is made. The machine is then moved away, the film retrieved, and the patient is ready for dismissal. Now we would like to illustrate a common error in this technique. The position of the patient and insertion of the film are both acceptable. The angulation was correctly computed. This exposure, however, would result in cone cutting because the central ray is directed at the incisal edges rather than at the root tips of the anterior teeth. This film illustrates another error in technique. The anterior mandibular segment and the incisor teeth are elongated well beyond actual anatomic measurement. This results from an incorrect angulation. Here the central ray is correctly aligned, but if the angulation was incorrect, as now, the result would be an elongation such as shown in the previous radiograph. Incorrect angulation is usually a result of an error in setting the 60-degree difference from the measured plane of the film as earlier described. This is a mandibular cross-section occlusal radiograph. It shows all the teeth from a viewpoint along the longitudinal axis of the teeth. They are seen then essentially in cross-section. The projection is useful for noting the alignment of the lower teeth. The floor of the mouth is well visualized to show foreign bodies or calcification lodged in the soft tissues, glands, or ducts. The bucco-lingual relationship of impacted or supernumerary teeth or other pathologic lesions can be evaluated in this type of occlusal radiograph. In case of fractures, the degree of displacement can be determined. For this radiograph, the patient is again positioned with her head tilted far back. In a frontal view, the mid-sagittal plane of the head must be vertical. Using the typodont for demonstration, the packet will be inserted in the mouth. The sensitive side of the film must be placed downward against the lower teeth. The long aspect of the film will be placed from side to side in the mouth and positioned symmetrically. About 1/4 inch of the packet should protrude anteriorly. With the patient's head tilted far back, the film is inserted and positioned as was illustrated on the typodont. The patient gently closes to hold the packet in place. The X-ray machine is moved into position, and the vertical angulation is adjusted so that the central ray is perpendicular to the film. Now the upward angulation is increased by 10 degrees to account for the distal inclination of the roots of the teeth. With this accomplished, the machine is repositioned so that the central ray will pass along the mid-sagittal plane at a point opposite the first molar area. A taut string may be used to check the position if desired. Viewing from above the patient's head, we are able to ascertain that the central ray is aligned along the mid-sagittal plane of the patient's head. The exposure is then made, and the machine may be moved away. The film is carefully retrieved, and the patient is ready for dismissal. This radiograph illustrates a common error in technique. The beam did not expose the whole film. This is another example of cone cutting, and is a common error in this type of occlusal projection. It is usually caused by positioning the X-ray so that the central ray passes through the incisor area rather than through the first molars. On the patient, note the error in positioning. The central ray passes incorrectly through the anterior teeth. Another error is illustrated here. The vertical angulation is incorrect because 10 degrees were subtracted from rather than added to the vertical angle indicated when the central ray was perpendicular to the film packet. This error will cause the teeth not to register in true cross-section. Assuming, however, that the positioning of both patient and X-ray has been carefully done, the radiograph will give the dentist the desired view, and the patient will benefit from the information derived from it.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.